So, thank you very much for inviting me and Dr. Ingrid Rekeland from Haukeland University Hospital in Norway. So we're going to talk for about 1 hour, or for a few minutes together. We will change in the middle of the presentation. So we're going to talk about some studies that we have been performing. It's about B lymphocyte depletion as a therapeutic principle in ME/CFS. And it's about some efforts trying to understand the mechanisms of disease. Can you hear? Yeah, okay. So, no. This one is not working.
You can use this as well.
Yeah, there it is. This is our research group at Haukeland with Olav Mella and me that started this project in 2008, and all our collaborators. We also have an interesting collaboration with the University of Bergen, with the Department of Biochemistry, with Professor Tronstad. And because we are doing a multi-center study in Norway, we have several collaborations with hospitals in Norway that I will tell you about. And also some national project in Norway, together with University of Oslo, of immunogenetics. These are projects that are ongoing. We have, I have to mention the Kavli Foundation, the Kavli Trust, that has been crucial for our possibilities to do research. And we also have received funding from the Norwegian Research Council, the Norwegian ME Association, a private organization called Me and You, and from the regional health trusts in Norway. And we have a conflict of interest because our hospital has applied for a patent for the principle of B-cell depletion in ME/CFS. So, Dan Peterson has been talking a little bit about the criteria, so I will go quickly through that. But just reminding you that we are talking about ME/CFS according to the Canadian criteria, in which some of the hallmark core symptoms are the fatigue and the malaise after exertion, the post-exertional malaise, and also the important aspect of sleep disturbances with inadequate relief from sleep or rest, and a lot of other symptoms, often cognitive symptoms that he told you about, and the long list of autonomic symptoms and immune-related symptoms that can vary among patients. It's about probably 0.2% of the population, maybe 0.3%. We don't know for sure. And it has to be distinguished from the more general fatigue without these other symptoms, which affects maybe 2 or 3 or even more % of the population. About 4 times more common in women than in men. And as you all know, varying from a moderate reduction in function level to severe and very severe disease. Our interest in this field was a little bit not planned. In 2004, we had we are oncologists. I'm working on lymphoma and brain tumors in my daily work. Dr. Rekeland is also oncologist, and Dr. Mella. So we are not, from before 2004, we had no knowledge about ME/CFS. But in 2004, we had patients with long-standing ME/CFS who got Hodgkin lymphoma. And as part of one of her chemotherapy regimens that she received, received a drug combination with methotrexate and ifosfamide included. And when she received that one particular regimen, she reported to us that she had a considerable relief of her ME symptoms for 5 months duration during and after the chemotherapy treatment. So we were just thinking about this for the next few years. This was unexpected both for the patient and for us. And we were asking ourselves, could this be a hint that chemotherapy, that's also has functions in the immune system, Could it be that ME is an ongoing immunological disturbance? And we were thinking at that time that maybe this is some variant of an autoimmune mechanisms. Some hints could be that it affects women, but about 80%, which is common for the autoimmune diseases. And it often follows infections. Like we have heard before today, about 70% after infections. And some of the autoimmune diseases are caused by B cells and the humoral immunity, autoantibodies. And we were thinking that maybe this is an example of a B cell-related autoimmune mechanism, a variant of that. And we decided to try an antibody called rituximab, which is directed against the molecule on B cells. This is a schematic presentation of an antibody, which is directed against a special epitope. And if you look at the B cell maturation, this is a rather complex picture, but the only thing I want to stress is that the B cells, they mature from stem cells in the bone marrow, and they go through this very long education, ending up as plasma cells that are designed to produce antibodies, protective antibodies that we should use to defend ourselves against the virus and bacteria and so on. And the CD20 molecule is present on all these stages of B cells, but not on the stem cells, and not present on the mature plasma cells. So if you give rituximab, you reduce all the intermediate stages of B lymphocytes. And B cells have important functions in the immune system, both making antibodies, but also in regulation of other cells in the immune system. So giving rituximab gives a transient depletion of all these intermediate stages of B cells, but luckily, because the stem cells are not affected, they will grow up again. So when we had given the first patient rituximab, we saw that she had a response on her ME symptoms. We decided to do a small case series with only 3 patients. We gave these a single rituximab infusion and just observed what happened to them. And we saw that all these 3 patients had a transient effect on the ME disease symptoms. And we made a small case series of this in 2009, me and Olav Mella. And while we were publishing that, we had another lymphoma patient coming to our hospital. She had a very aggressive lymphoma with a large tumor in the mediastinum, in the chest. And she had had severe ME for 8 years, I think. And she, exactly 4 months after she had started her chemotherapy, which was 8 courses of rituximab combined with a standard chemotherapy regimen, which also includes cyclophosphamide. You can see this R and the C. And from 4 months after treatment, she had a long-lasting and very impressive response on her ME symptoms. During the last 3 years, she has had some partial relapse of the symptoms, but she's still 7 years later, 8 years later, still in a moderate response. So what we had seen from these initial experiences was clinical improvements after rituximab intervention in 1 patient with ME-CFS with lymphoma, and 3 pilot patients with only ME-CFS given single rituximab infusions. So the question was, is this just a placebo mechanisms, or is this a sign of some kind of clinical activity? Is there something here affecting the disease picture in a subgroup of patients? How should we proceed? Should we just forget it, or should we try to convince ourselves and maybe some others? That's why we decided to do a very small randomized trial where we gave 30 patients with ME-CFS recruited from the Department of Neurology. We gave them either 2 infusions of rituximab or 2 infusions of placebo, which was only saline, and observed the patients for 12 months. And when we designed that protocol, we were thinking that maybe we will see some effect at 3 to 4 months after treatment, and that was the primary endpoint of this study was to look at the difference at 3 months. This is a scheme of the main result from that study, and the red ones are rituximab patients. Can you hear me in here? And the black ones are placebo patients, and these are the time intervals from baseline until 1 year. And this is a scale. 3 is no change from baseline. 4, slight improvement. 5, moderate improvement. 6, major improvement. And worsening, slight, moderate, and major worsening of symptoms. And you can see that at 3 to 4 months, there is absolutely no difference between the groups. So the primary endpoint for this study was negative. But the secondary endpoints were positive. Later on, during the follow-up, you can see that the red ones are more up here. 2 from the placebo group had a sustained effect and was characterized as responders. 2 out of 15, while 10 out of 15 in the rituximab group experienced a clinical response, which was significant. So this was some kind of hint of a clinical activity. And then we tried to explore a principle that we have seen used in low-grade lymphoma patients for many years, what we call maintenance treatment. Because if you can see that we had transient responses, maybe half a year, maybe more, but then relapse of symptoms after single or double rituximab infusion, what if we gave the patients repeated infusions? This is R means a rituximab infusion, and this is one of the pilot patients, which was included in the first case series. First, we gave her a single rituximab infusion, and then you had a lag time of 20 weeks, or 5 months before she experienced a marked clinical response on all the symptoms. This response lasted for about 14 weeks. Then she had a gradual relapse. When we gave her a new rituximab, we saw almost exactly the same pattern. So that's why we were thinking, what if we do like this? Trying to prolong the B-cell depletion period to sustain the responses. That was our thought. So this is a little bit complicated slide, but I'll try to show you because it tells us something important. This is the time axis. This is the same patient. She had 20 weeks lag time from the first rituximab infusion. And when you give rituximab, the B cells drop to 0 or almost 0 very fast, within a few days. But because the stem cells are not touched, as I told you, they will start regenerating. Often 3, 4, 5, 6 months after the last infusion, you see that the B cells start rising. So this tells us that after 20 weeks, she has a response, lasting for 15, 16 weeks or something, and then she had a relapse. Look here. When she started to feel response, she has an increasing B cell number at the time that she experiences response. And even though we gave her the second rituximab while she was in clinical response and drops to 0 in B cells, she yet had a relapse. And when we then gave her sustained repeated infusions, she has stayed in response for more than 6 years now, without the relapse. She had 6 infusions in total, and then observation. So this tells us something. It's not the B cells themselves that's causing the problems. It's something produced by the B cell, or related to the B cell, some kind of X factor that has the characteristics of a slow elimination after B cell depletion and a slow rising after B cell regeneration. Did you understand that from this plot? So that's why I used some time for this. So this is either produced by B cells or regulated by B cells. Could be an antibody. That's what we have been thinking. We have not proven that. So that's why we decided to do a trial with rituximab maintenance treatment. The B lymphocyte, maybe it's better look there for you. The B cell lymphocyte depletion in ME/CFS, which is an open-label phase 2 study. And this is the weakness of this study is that it is open-label. There's no randomization and no placebo group. The patients received first 2 infusions of rituximab, like in the first study, but then maintenance after 3, 6, 10, and 15 months. And 28 patients received rituximab maintenance. In this study, 18 out of 29 patients that were included, one of them did not get more than 1/2 infusion because he had an allergic reaction, but 62% of those included in the study had a clinical significant response according to the criteria that was predefined. That means that almost 40% had no clinical response. And within the 3 years follow-up in this study, those 18 responders had a mean duration of response of almost 2 years. So they were pretty sustained in that study. After 3 years, 11 out of the 18 were still in response. After 5 years, 5. And after 7 years, now only 3 patients are still in remission. So it seems that many of the patients are getting relapses, some after 1 year, some after 4 years. It's difficult to say on beforehand. But we could say that the maintenance treatment was associated with prolonged response duration. But we should also mention that we have tried to treat very severe patients with rituximab, 4 patients, but none of these have had a clear, significant response, so that they have been completely bedridden and needing help for all tasks. So that group has not been a success so far. I think I dropped that one. This is a scheme for the SF36 questionnaire, which are self-reported symptoms, 36 symptoms filled in by the patients at the 3, 6, 10, 15, 20, through follow-up in the 3 years. And I'm not sure if you can see on this plot, but based on these questions, you get the score for physical function, vitality, bodily pain, social function, and mental health. And the time is indicated on the x-axis, and I've divided this in the 18 responders have been divided between 14 that we have characterized as major responders. The green ones are what we have called moderate responders, and the blue one are non-responders with no effect from the benefit from the treatment. What you should see that, for instance, for social function, baseline for the major responders, baseline for the moderate, and baseline for the non-responders, extremely low levels. Also for vitality, very low scores at baseline, indicating what the patients tells us. They have a very high symptom burden. And you should also see that after 3 months, there's no difference. You can see. But after 6 months, and when you go further in the study, you can see that the curves are increasing, especially for the major responders, to some extent for the moderate responders, while it's almost flat for non-responders. And you should also see that these patterns, except for mental health, which is quite flat through the study, you can see that this pattern looks very much alike for the different domains of the disease. So when the patients start telling us that they recover physical function, it's often followed by improvement in symptoms, also for the pain, vitality, and social function, because these self-reported symptom scores, they seem very much alike. So what we see is a lag time. It takes about 4, 5, 6 months often before patients start to recover. And the maximum level of response, you can see here about 15 to 20 to 24 months after start of treatment. These patients have got 6 infusions, as I told you. We tried to see if the serum rituximab concentrations were important, telling us who responded and did not respond to the treatment. This is the time where you see the R's are when the patients got rituximab. You can see the serum concentration are very much alike for responders and non-responders. So it didn't seem to be the concentrations of rituximab that was the main point. So the tolerance and the side effects from this maintenance trial. 2 patients in this study had an allergic reaction with a skin rash and from rituximab treatment, which is an artificial protein that we give intravenously. 2 patients had what we know from lymphoma treatment with rituximab, a late onset neutropenia. That means that when the B cells start recovering, often in the blood, you can have some kind of maturation stop in the neutrophil granulocytes, which are important white blood cells. So you can have a 4 or 5, maybe 1 week, maybe 2 weeks with low neutrophils, which were uncomplicated. But it's important to know, because if patients have neutropenia and get infections, they should be hospitalized to get antibiotics, because the immune system is lower. But it occurs in about 5 to 10% of lymphoma patients. 28% of the patients reported worsening of symptoms the first weeks or days after a rituximab infusion. So there seems to be something that's triggering symptom activity initially after rituximab infusion in this study. One of the patients experienced a sustained worsening of symptoms. So we could ask the question, do some patients with ME/CFS not tolerate the drug? So that's why we do not support treatment outside clinical trials until we have some more evidence. So these 2 small studies have many limitations. I'll tell you about that, because the first study was the first one to evaluate this treatment principle. This was not a very detailed definition of the criteria for overall response in the first study, and the primary endpoint was negative. And you could have what is usual to have in small studies. You could have a selection bias. We could not know if the patients that we had recruited were representative for a larger population of ME patients. And the maintenance treatment with 6 infusions was open label with no placebo group, and is explorative. So we have to reproduce the data. And that's why we have been performing now RetuxMe, which is a multicenter national randomized, double-blind, and placebo-controlled phase 3 trial with rituximab induction and maintenance treatment in ME. And the purpose here is to either verify or refute. Is it a clinical benefit from giving rituximab to ME patients? There's 151 patients, 75 or 76 in each of the 2 groups, 5 centers in Norway. They get 2 infusions with either rituximab or placebo, initially 2 weeks apart, as in the 2 first study, and then maintenance 3, 6, 9, and 12 months, but with a lower maintenance dose, 500 milligrams. I'm not sure if it was wise to reduce the dose, but it was to get the study up and going. Double-blind design. So I can tell you that we are working very hard now, closing the database, going through every, looking at there's no data missing before we, and we made all the criteria that should be planned on beforehand, the statistical analysis plan, everything is now ready. And we plan to open the code in a few weeks from now, in October. Because all the patients have been through 24 months follow-up, and it's now just checking that everything is okay, and then start to do the analysis. So the primary endpoint here is the fatigue score, which is the same that I showed you in the first study. The patients self-report symptoms every 2nd week on a special form, always comparing to baseline. Do they feel slight improved, moderate improved, major improvement, or worsening compared to baseline? To try to get some objective measure, we also have this armbands measuring physical activity that the patients use for 7 days continuously at baseline and repeated after 18 months, measuring how many steps the patient walked, the total energy expenditure, active energy expenditure, and so on. And several other symptom scores, including the SF-36 every 3 months that I told you about. We're doing sub-studies with endothelial function, exercise test for 2 days, and gastrointestinal function at baseline, and we repeat those tests after 18 months. So the criteria are ME at the Canadian criteria, 18 to 65 years, and yes, you have been sick for between 2 and 15 years. We have severe patients, but not the very severe patients that need help for all feeding and cannot do any tasks themselves. Just show you some baseline characteristics. 151 patients have started intervention. Mean age is 39 years, from 19 to 65. 82% are women. They have a mean body mass index around 25. 30% in this study has either severe or moderate to severe disease. 30% has been classified as moderate, and 40% either mild or mild to moderate. 60% has been ill between 5 and 10 years, 20% longer, and 20% between 2 and 5 years. We just looked at some baseline characteristics. We see that about 40% of the patients have a relative, either a child or a parent or a sibling, with known autoimmune disease. And 60% have tried cognitive behavioral therapy, could be lightning process or mindfulness, and so on, without success. Just to show you 3 examples of these patients. This is an example of a non-responder. It's just a plot from 0 to 104 weeks, which is 2 years. The fatigue score, which is reported by the patients every second week, is in this green line. 3 is no change from baseline. This is improvement, and this is worsening. And you can see that the green line is around between 3 and 2. 2 is slight worsening, but almost unchanged from baseline. These are the rituximab infusions. And the steps is 1,480 and 1,960. It's a small difference. And this one is the self-reported function level, which is almost flat. It's about 15% to 20%, according to a scale with examples. They pinpoint this is where I start, about 15%, and this patient's end up about 15%, according to a scale with examples that we have made. This is a moderate responder, that you can see the same time axis. You can see the level of functioning, which is very low at the beginning of the disease. It's a patient with severe ME, 27 years, been sick between 5 and 10 years. And she's almost stable both in the fatigue scores and in the total level of functioning, until she starts to feel improvement from about 9 months after treatment. And she has what she first interprets as a slight improvement, a moderate improvement, and what she, compared to baseline, characterizes as a major improvement here in the end of the study. The level of function level, except for this influenza episode, is about 35% at the end of the study. And she increases from 1,000 to 2,800 steps mean in a week when we compare after 18 months and baseline. And this is a major responder in this study. We don't know if she's got rituximab or placebo. Remember that the R's here are just indicating that she had treatment. It could be placebo. We don't know. That's one of the things that we're going to find out. If she's placebo, we are in trouble. That's okay. We're trying to do our best. So this is a patient. You see that soon after start of treatment, she feels a drop to a moderate worsening lasting for a month or 1.5 months, a transient worsening of symptom. And then she has a rather steep improvement in the fatigue score, which is between 5 and 6 to the end of the study. And she walks 686 steps, almost completely bedridden, and it's more than 5,000 when we measure again. So she has a gradual increase in her function level. This was also a patient with severe ME. So we have all the different categories of response But we also see patients that are worse than before starting treatment, and it's equally important for us to see how will the responders divide, but also if there are patients with sustained worsening of symptoms, will they be a majority in the rituximab group? Then it indicates that some patients don't tolerate this immunogenic stimulus. But if they are evenly divided, that means that the workload for the patients coming to the hospital 15 times, getting 6 IV infusions, has major implications, even though it's inactive drug. That's an important thing to clarify. So the side effects that we are looking into, we have some infusions-related reactions. We have the late onset neutropenia that I told you about. And we haven't seen this, but it's very seldom, but we can have reactivation of chronic infections, tuberculosis, hepatitis. So if you have had hepatitis B or C, you should not go into such a trial. In the previous study, we saw that 28 patients had this worsening that we saw in this responder immediately after rituximab or after infusions. So this is an important question that we must answer. Do some patients not tolerate the treatment? So we will open this code in October. We have no information of the rituximab and placebo groups yet. How will the responders divide? How will the patients with worsening divide? That will be the crucial thing for the study. Just to show you one small example of follow-up data, we have measured steps in this study. And you see that at baseline, it's about 3,200 all patients together, rituximab and placebo group. We don't know yet, from 252. This was a marathon runner that had mild ME, but she was used to running marathon, and she had the disease, even though she has a high function level. That's an exception. That's an outlier. But you see that it's very equal between the 5 centers, about 3,000 to 3,600 in mean steps per 7 days, per 24 hours. And when we repeat this after 17 to 21 months follow-up, you can see that if you look at all the patients together, all patients given both, even including both responders and non-responders and those with worsening of disease, you can see that there's a slight increase in the mean steps per 24 hours when you from baseline to 18 months after treatment, which is significant. It's not much. It's from 2,888 to 3,300 for the complete group. That's median value, not the mean value. Mean value was a little bit with 3,200. It's probably most correct to use the median value. And you can see here, if you look at the lines for each patient, some of them are very steep, from 1,000 to 10,000. Some are going down. Many are like this. You can see that. If you remember that these are patients given both rituximab and placebo, we don't know who has got what. But if you look at only those that meet the criteria for clinical response in this study, I can't tell you how many that is. But then you can see that they increase the physical activity level much more. So there's something telling us that those reporting improvement, they increase their activity level. These are the lines for each patient. Some of them dramatic increase, some of them actually going down, means that that week they were going with their armband, they didn't feel quite well, and had to, even though they are classified as responders. 2 words last about the cyclophosphamide study that we are also doing. That's because we know that 40% of patients in our previous study had no benefit from rituximab. So why should we give cyclophosphamide? We have seen 3 patients with long-lasting ME who had breast cancer, who received adjuvant chemotherapy, and all of them reported independently from each other about this has major effect on my ME disease. Then we treated 3 pilot patients with ME with 6 IV infusions with cyclophosphamide. 2 of these 3 experienced a clinical response. and one was a non-responder. One of these pilot patients had a 17 years history of ME, severe and bedridden in the last 3 years. Her activity measurements measured 300 steps per 24 hours, and she had a significant response. And still, more than 3 years later, she can walk about 8 to 10 kilometers, not every day, but between 2 and 5 days every week. So she has a very changed life, but she would not characterize herself as being completely healthy. But it's a large difference still. So cyclophosphamide is an old drug that has used for cancer treatment, but it also has a broad effect on the immune system. It affects both, a more unspecific effect on the immune system than rituximab, affects both the B and the T cell, cell-mediated T cell immunity. It's used in autoimmune conditions, especially earlier, like lupus, vasculitis, rheumatoid arthritis, and in multiple sclerosis. So we have started the cyclomete trial, which is also finished now, with 40 patients given cyclophosphamide, 6 infusions with 4 weeks intervals. 25 of the patients had never been given rituximab, but 15 patients had had rituximab earlier, either with no response to see could this be an alternative in non-responders, or in patients with response but then relapse. So there's more toxicity in the early phase with cyclophosphamide. You have more nausea, all patients, for 1 or 2 days, maybe 1 week or 2. Worsening of symptoms the first week after treatment, but we don't see the very sustained long symptom worsenings. So maybe it's more difficult for the patients in the short term, but it's not an immunogenic stimulus like rituximab could be. We have 8 patients with irregular menstrual periods during the treatment, between 48 and 47 years old. 2 of them maybe had a premature menopause, both of them 43 years or older. But no hematologic toxicity. I can say that approximately half of the patients are experiencing clinical response. And we have started, also patients with no response to rituximab have experienced response. That's interesting to us. We started a pilot study for patients with severe or very severe disease. We're only going to treat 3 to 5 patients to see if they can tolerate this treatment. And then we have planned to extend to 20. So I'll finish in a minute. Just show you some armband data for the cyclomete trial, showing that these are steps per 24 hours, measured at baseline for all patients, all the 38 patients that completed follow-up, for those experiencing response and for non-responders. Now you can see, I won't tell you exactly the number of responders, but it's approximately half of the patients. You can see that because it's preliminary yet. The non-responders, no change in physical activity through follow-up. The responders, they have, these are from 3,000, about 3,500 mean steps per until about 6,000. And if you look at the complete group, which is the most relevant analysis, because all these patients have got rituximab, it's a phase 2 study, you can see that there's a significant difference from baseline to the 9, 12, and 18 months follow-up. So I think that this study will give us important information. So this is the one I will stop with, and I will just tell you that what I've been talking about now is rituximab and cyclophosphamide. We believe that some kind in this disease, the immune system puts some adverse events, maybe an autoantibody, maybe in some patients cell-mediated immunity, affecting a system that generates the symptoms. Why does the patients have this devastating energy deficit? Why do they complain about lactate problems when they do the smallest exertions? What we are trying in the next half hour is that Dr. Ekeland will try to convince you that we have a publication and some data how we think the immune system, what this immune system affects to give the symptoms for the patients. Okay. So she will continue and we can take questions afterwards.